Don't say anything funny. Hi, everyone. Thank you for being here. My name is Valerie Bogdan Powers. I'm the president of Horan Health. First of all, welcome to our new facility for those of you who have not been here. And we were really excited when we built out this facility to have the ability to bring back our sessions here in our office. And we think it brings a different impact. So thank you for coming. As the president of Horan, I do the obvious things that are in my title. I work on the client deliverables with the team and our growth strategies and our operations. But I think for me, what I'm most proud of in my role is really being what I would call a people promoter. And hopefully many of you experience that with our teams, to be and have a high energy culture, which hopefully you also experience with our teams. And then what we're talking about today, which is to be a horizon explorer. And as we think about the horizon and where we're going and what we're doing, there's so much in the marketplace. And how do we digest it for you? How do we link it to where your strategies are? And how do we also help you say no to a lot of things that may not be where you want to go? And that's all good. So that is hopefully today is the hope that we inspire you and inform you with a lot of things that are in the marketplace. It would not be a proper Horan meeting unless I reminded you about who we are at Horan, as most of you are clients, but not all of you. But some of the things that we're most proud about on this slide are, one, how long we've been in business, which we are facing our 75th anniversary this year. We're really excited about that. Two, that we have over 600 clients between here, Dayton, Columbus, and Kentucky. And so we really have a strong regional presence, which we value and also can bring a lot of learnings to you. And that puts us in a unique place nationally as an independent agency, which we're also proud of. And then the last piece is just really all of you. We maintain a 95% retention rate of clients, which is above the industry norm at about 86%. And that's also including a lot of clients who are in the space where they get sold and move into a bigger corporation. So it includes it all. And that's a testament to all of you and the work we do and the faith you have in us. So thank you. So today we have four main topics. So as you think about today, what you're going to hear and learn is we've broken it down, and we did what we would say the hardest topic is really compliance always, and analytics, and then pharmacy. And then we're going to wrap it up with total rewards, which is really a little bit more fun and light. So we just thought, you know what, we're going to hit you hard early, so you'll be there, and then we're going to allow you to have a little breath at the end of it and go, oh, okay. So just want to put that out there. Each section will have a good analysis of what we have seen, what we see coming in the future, and some things to think about. And then as you meet with your teams from Horan, how do we then decide which of these you want to explore deeper and go into? Okay, and we'll leave some time for Q&A, but feel free if you have stuff along the way. We're not shy, so feel free to ask. So our presenters are here: Shelly Hodges-Konis, Mike Lakin, Michael Jeffries, and Cheryl Muller. We're going to start with compliance. And as you think about compliance, you all know, as much as we know, is it's getting more and more complex. And different regulations come, different pieces come. And I just want to make sure, as you think about Horan and how do we tap into it, we have obviously Shelly Hodges-Konis here, who's been with us for 20 years, who has both been in the client services roles as well as running our compliance department. But we also tap into a lot of other things you should know about. We tap into NAHU, which is now called NAPIP, which is our National Association of Insurers, which sits in Washington and does a lot of lobbying on behalf of the insurance industry. We're part of CIAB, which is an association, a National Association of Brokers, which also does a lot of government work. Ohio Association of Health Plans, I personally have gotten involved in. We helped pressure, or whatever you want to say, the word is Ohio Bill 135, which was against the high deductible health plans and some of the things that would detrimentally affect costs to the employers. And we were able to push against that as a united front. And then broker advisory boards, which many of our leadership people, including me, are part of. And there we get a lot of information from their government affairs and can give feedback on the behalf of you of what they're seeing, because they do influence legislation in very meaningful ways. So with that, I'm going to, many of you know Shelley because you've met her. If you haven't, I highly recommend a comprehensive compliance review with Shelley because it's very informative. But today she's going to talk a bit about where we've been and where we're going.
Thanks, Val. I don't know what it is. I hit my 20-year anniversary in August. We just celebrated it together as a company recently, and everyone likes to talk about it. But what I want you to know to set the record straight is I actually started with Haran when I was like 15, okay? When we think about compliance and we think about future prepping, just preparation in general, preparation is supposed to lead to success. And it always feels overwhelming and really difficult when you're talking about success and compliance, even for me. And so what I hope to do today is give you some kind of a framework to think about compliance and how to plan for it by looking at what may come in the future, or what might be on the road ahead, what we're dealing with right now, and what are some key things that you should keep in mind when you're adding to your benefits plan, changing your benefits plan, just to make it a little easier on you. So we'll start with kind of the road ahead. This is not really crystal ball things. These are all things that we have an indication about already. But the first is the Supreme Court's decision last summer in Dobbs versus Jackson and the impact of that. And really, it doesn't have a direct impact on benefits, but it has an arm's reach impact on benefits. And so what the Supreme Court decided is that there's not a federal right to reproductive rights or abortive procedures. Okay, thanks. Or reproductive procedures, that people don't have a guaranteed federal right to that. And so the decision really put whether or not a procedure is legal or available in the hands of the state legislature or in the hands of the people, as the Supreme Court phrased their decision. And so what that means is it puts employers in a position to have to know what's covered under their benefits plan and whether or not that procedure is actually even available in the state. And we don't know how that decision might have ripple effects into other benefits provided by the employer. We also don't know what ripple effects that the decision could have in ERISA preemption. If you're fully insured, you're subject to state law, and so the laws of the state and state insurance coverage apply. When you're self-funded, you have ERISA preemption, which means that to the extent that state insurance laws apply, your plans are not subject to those state insurance laws. But this is just a developing area to keep an eye on, nothing to do right now, but something that could have an impact down the road. So something to keep in mind, tucked in the back of your head. The Biden budget bill has no direct impact on benefits today, but some investments and some key indicators in the Biden budget bill are related to healthcare prevention. That's because for the second or third year in a row, the average life expectancy of a US citizen has declined. So, average life expectancy in the United States used to be over 80 years old. It is now, I think, around 78.6 years old. So it's on the decline, and that's concerning for a couple of reasons. We spend so much money on healthcare in the United States, and for developing nations spend much less and have much better health outcomes. So that's a concern for the current administration. They have put a lot of money toward eliminating gender and racial disparity in healthcare, trying to close some of those gaps, and improving the high infant mortality rate in the United States. So a lot of money is being devoted to the Department of Health and Human Services, to the Centers for Medicare and Medicaid Services, and trying to improve some of those outcomes. What I expect we may see as a ripple impact in the benefits industry is that preventive care mandates may increase under this administration through executive order or through recommendations by the United States Preventive Services Task Force. So if you all know, the Affordable Care Act mandates that preventive services are covered at 100% under your group health plan. We may see an expansion of those services under this administration for that reason. And the last thing that's really on the road ahead is that as we increase technology in employee benefits, as the technology industry seeps into everything we do, there's a focused or heightened awareness or attention on data security. So a couple things have happened related to data security. About 2 years ago, the Department of Labor issued cybersecurity guidelines applicable to retirement plans and best practices in picking your service providers and how to make sure that employees' retirement information and data is secure. There is the possibility that those regulations will bleed over into health and welfare plans as well, so that when you choose your health and welfare plan vendors, that those same data security best practices will apply. There are also a lot of state evolving data security laws that involve protected, personally identifiable information rather than protected health information. So that personally identifiable information leads into your life insurance plans, your disability plans. So know that certain states that are taking a more, like California, for example, are taking a very proactive approach related to data security. And the last thing that just really came out about a month ago were guidance from the Department of Health and Human Services, the Office of Civil Rights, applicable. So if you're a self-funded health plan, this is really where it's more of interest to you. And you're subject to the Health Insurance Portability and Accountability Act, protecting individually identifiable health information of your plan participants. Covered entities have to be careful when they are implementing data security about the technology that they implement and the cookie tracking capability in that technology. So I'll give you kind of the current example that's out there related to healthcare. If you have, so providers, so hospitals, or doctors, they use the MyChart app a lot of times. When you have that on your phone, if you have Facebook open at the same time, Facebook's cookie tracking technology can actually track where you've been. So this is a caution from the Department of Health and Human Services to investigate your technology, to know how it works and know how it interacts with other technology. So I tell you all of that just so you have the ability to see the road ahead and to know that these things could have an impact on the decisions that you make going forward. Keep it up here. All right, will do. It's really weird because where I stand, it sounds very loud. So, okay. All right. We'll go. I will get on my own nerves and not on all of yours. You'll actually be able to hear me and I will drive myself crazy in my own head.
Talking to your boys.
I will use my mom or my teacher voice. All right. So where are we at right now? So we've kind of talked about where we might be going related to benefits. Where are we right now? Right now, related to the COVID-19 national emergency, the Biden administration has announced a coordinated end to both the public health emergency that exists and the national emergency. Seems a little confusing, but these are two different things. The national emergency is declared by the president, and the national emergency gives the protections that are available through the Department of Labor on some of those extensions of time. The public health emergency actually requires certain coverage under your group health plans. All of that will wind down as of May 11th. So what does that mean? As of May 11th, under the public health emergency, plans will no longer be required to cover COVID-19 testing at 100%, both in and out of network. That will go away. Vaccination will remain because vaccination is now required coverage under the ACA and the preventive services mandates. As of May 11th, we'll begin to see the rollback of those national emergencies, extensions of time issued by the Departments of Health and Human Services, Treasury, and Labor that give extra time for HIPAA special enrollment events, COBRA election and payment, and claims and appeals procedures under ERISA. So those end as of the end of the outbreak period. So not with the end of the national emergency, the end of the outbreak period. So the outbreak period, if you'll remember, ends 60 days after the end of the national emergency. This means that 60 days after that date, so July 10th, approximately, if I'm doing math in my head right, somebody check me, that the special enrollment window will close. So keep in mind, though, that the standard timelines are included in that. So people have the lesser of 1 year from the date of their event or 60 days after the end of the national emergency, plus their standard timeline to request a HIPAA special enrollment under your plan, elect COBRA, make their payments. So just have that on your radar. We'll keep you informed of how that impacts you once those announcements really become official.
I just have a question related to the COVID and kind of like the state regulations, specifically California, because they kept extending that employers provided paid time for full-time and part-time employees. Did that get extended or did that end at the end of December?
I can't really speak to extension. Oh, her question, yeah. So her question is around extended leave in California related to the COVID-19 national emergency. And I can't speak to the state of California right now off the top of my head, but if you want to get with me afterwards, I will take your question. So self-funded employers related to the wind down of the national emergency actually will have some flexibility to determine, do they want to not cover COVID-19 diagnosis in and out of network, or do they want to continue it? And what you should look at is, are any plan amendments required to make that happen? In a fully insured world, your insurer will make those decisions and they will update any documents for you through your certificate of coverage. Two priority agenda items for the Employee Benefit Services Administration, or EBSA, are mental health parity compliance and transparency requirements that are remaining. So mental health parity, this is the law that says that if you cover mental health and substance abuse benefits under your group health plan, that you have to provide it equal to any medical or surgical benefits under your group health plan. The Consolidated Appropriations Act of 2021 implemented a requirement on plans to make a comparative analysis of the mental health and substance abuse benefits covered under their plan to the medical and surgical benefits. Basically, what the departments are saying is, if you cover mental health and substance abuse benefits, you have to prove that you do it equally to medical and surgical benefits. Most plans have not taken any steps to actually conduct a comparative analysis. If you have taken steps to conduct a comparative analysis, you are ahead of the game. Last year, in the report to Congress about mental health parity compliance, I think 152 to 158 plans were requested information of. None of them were compliant. None of them were sufficient to prove actual parity between the medical and surgical benefits to the mental health and substance abuse benefits covered under the plan. So the Employee Benefit Services Administration has said for this year, they plan to propose amendments to clarify the obligations of both self-funded group health plans and health insurers, their obligations for compliance under mental health parity. So to make it a little more clear who's responsible, and to provide a path and make changes that promote actual compliance with the law. So all of that to say, if you have not conducted a mental health parity comparative analysis, because this is a priority area for compliance, that you should make an outreach to your insurer, to your claims administrator if you're a self-funded health plan, to at least receive information and then start to question it. Okay. Now, if you want to do a full mental health parity comparative analysis and you want to engage legal counsel's assistance with that, or you want to engage the assistance of a vendor to read through all of the material and point out the areas where it's unclear, we can help you with that as well. And then when I say transparency, I probably will get a lot of looks. Aren't we done with transparency yet? Haven't we met all of the requirements? This transparency has been going on for years. And that's true, but there are a couple, so you probably have a headache from just getting through RxDC reporting and providing information to your insurer or your claims administrator so they could complete reports on your behalf about the prescription drug cost through your group health plan. That requirement's coming up again and due on June 1st. But there are a couple other and effective as of January 1st of this year. insurers and group health plans had to provide a tool to shop the 500 most common services to see what the pricing for those services was under that particular plan. Effective as of for plan years on or after January 1st of 2024, that requirement will apply to all services under the group health plan. So we've got that coming up. The one that's still hanging out there is advanced explanations of benefits. The right for a participant to say, what is this procedure going to cost me out of pocket before I actually have it done? We're still waiting on regulations, but the Employee Benefits Services Administration has said that this will be a priority area that they intend to issue guidance on this year. Now, they say that a lot. Whether they do it or not remains to be seen. So, but best practice in the area of transparency that you should all be aware of is that most of the time your plan or your insurer is going to say, I'm going to do this for you. I've got you covered. And that's good. You should have it in writing. But best practice really is to try to find a way to contractually bind your claims administrator or your insurer to meeting those obligations on your behalf. All right. But that's a lot of information and that feels overwhelming. So here's where we really get to the framework of understanding and kind of having some tools as you make decisions related to your plans going forward. The first thing to know is that benefits innovation has far outpaced actual legislation. If you've been in the industry as long as I have, geez, I'm ruining myself here. I am as old as everybody says. Anyway, that benefit, if you remember in the industry, COBRA regulations were issued, or COBRA was passed in 1986. It took them almost 20 years to issue regulatory guidance on COBRA and actually finalize it. If you've been around long enough to know that cafeteria plan regulations aren't final, there's proposed regulations. So know that benefits innovation always outpaces legislation. So sometimes when you're adding a new benefit, or you haven't seen it before, the regulations aren't always going to give us the answers. We're going to have to make a best guess at how a regulation applies in a specific context. So that's probably the first thing you should know. But when you're adding something new, or you're looking at a new product, something that you haven't seen before, the question you should be asking is what laws could potentially apply, and really engage legal counsel in the conversation as you're moving forward. So, ERISA is a really broad law. Any plan, fund, or program maintained by the employer for the purpose of providing employee benefits. It's subject to ERISA. That means you're going to need a summary plan description, plan document. You're going to have reporting and disclosure requirements potentially. So that's something to be aware of. Next, if there's data involved, understand what data is being exchanged, understand what laws could apply there, and what the rules on that data exchange are. Are you permitted to actually share? That's the question you should be answering. And then finally, with all of those things in mind, what you need to understand from an organizational perspective is what's your risk tolerance? Am I the type of organization that I'm going to jump in both feet, going to leap, not look first? I'm going to be a pioneer. Is that your organization? If not, then you're probably going to want to take a more measured approach and really wait for more guidance or see who's in the pool first before you jump in and swim. Okay. All right. And then to wrap up, I want to just give you some basic questions that I always ask when I see something new, and kind of questions I ask myself. Is it an ERISA covered benefit? So I kind of gave you this one already. Is that benefit a group health plan? Does it provide medical care? If it provides medical care, it could be subject to COBRA. If I have a high deductible health plan, you better ask, does this benefit provide first dollar coverage, and could it invalidate my participants' health savings account contributions? Right now, we have telehealth relief for high deductible health plans through 2025, or until 2025, sorry, not through, until. So know that that's always something you should be asking. Telehealth generally is invalidating coverage, but it's not right now because of particular relief. And then, is there any data sharing?
Thanks, Shelley. So I told you we were going to start with the hardest topic. We did. We successfully achieved that goal. Thank you very much, Shelley. A lot of pieces in compliance. And again, I encourage you to really tap into Shelley and your benefit consultant with questions because we've probably been asked it before. Okay, we are moving into analytics. And one of the things that's really interesting about for us with analytics is we're really, I use the word proud a lot, but we are really proud of the journey that we've been on. We established what we called an outcomes team about 9 years ago, and it's the longest team we've had standing at Horan. And why that's important is we had a very simple mission. And our mission was to turn data into actionable insights. And that seems really simple now. It didn't seem that simple, by the way, in 9 years ago. But those truisms in our data is the linchpin that we talk to you all about of how does it drive your strategy? How does it drive your choices? We're fanatical about analytics and data. And so we thought it would be appropriate to give you some perspective of where data is and where is it going. Mike Lakin, our Vice President of Sales, who leads the overarching sales department as well as focus on Cincinnati and Northern Kentucky. And Kentucky is going to talk a bit about where we're going and where we've been. So thanks, Mike.
Thank you, Val. And Aaron Hamilton, all the way in the back, you have to raise your hand when you can't hear me. Okay. One thing we forgot to tell you at the beginning, we did bribe you all to come here to listen to compliance, data analytics, and pharmacy, really exciting topics. We do have HRCE credits out front once you finish. So make sure you access those as we go through this. All right, so data analytics. I always have to start off with a joke, especially with a topic that is a little mundane. But if you pay attention to the cartoon, really you can just make up data just like everybody else does. And I also made up the stat on the slide. I have no idea how many people use this, but 90% was just a completely made up stat. So I wanted to start with a short history lesson, and then we'll dive into a few things. I will highlight in your packet there when we get to spots that I want you to really remember and take away with you. But 2009 was really important as it related to data analytics. And the biggest reason was in 2009, providers and hospital systems were mandated to implement electronic medical records. And why that's important, for those of you that have been around since the 80s, your doctor used to sit in front of you and not stare at a computer. They wrote down on a piece of paper, and then that piece of paper had to get translated, and that piece of paper then had to go somewhere to an insurance carrier. That took a really long time for that data to actually flow through the system. So data prior to 2009 was really fragmented. All those paper claim filings took a significant lag on the system from when you actually had that service to when it got processed and paid, and then you can actually view any data. And really actionable information was very, very limited on what we would get as health insurance consultants, what you would get as employers, and really what your employees would get in the form of their explanation of benefits as well. And when EMR came out in 2009 and it was mandated, it was out before that, but when it was mandated, we saw the data warehousing became a thing. So now we went from having nothing to having way too much at the tip of our fingertips. So we need a source or a system to collect all that. And then we also saw a huge uptick on claims that were incurred and paid. So today, on average, every claim that's incurred is paid within a 90-day period. And that's about 90% of those claims. There's very little that lasts past that. So what does that mean? Well, that means everybody came up with a whole bunch of buzzwords that none of us really know or care to know what they actually mean. And so when we look at all these buzzwords, what do we do with all this stuff? And the theme that I want everybody to remember today is measure what matters. Take a look at all the data that you have at your fingertips and really drill down to the 3, 4, or 5 things that are most important. And that doesn't matter whether that's in healthcare, your business, or in anything else that you do, measure what matters. So not to be funny, but given it's coming up on March Madness time, and if you're like me, you donate money every year to your friends when you fill out a bracket and come in dead last. I figured we'd have a little game with measuring what matters. So on average, it's not a big deal, but on average, every team plays about 30 games a year. Every team has on average 16 players. 68 teams are invited to the big dance. And the NCAA tracks 13 statistics for every single player. Well, all that means is actually, well, you have 425,000 data points to choose to pick your bracket. Good luck figuring out what's the right one is. So really what's important with that, you really only need to focus on 4. So if you want to pick your bracket this year, focus on the team that has the ball the most and has the highest shooting percentage. Who can shoot well, who can create turnovers, who can create the least amount of fouls, and who can get the most rebounds. And then go in and start picking your bracket. Now, if you're like Val, though, every time Harvard makes the NCAA bracket, she moves them to the Final Four. That's not going to happen. So you still have there are still some outliers in there. So just make sure that you're focused on that as well. Seating does matter. So let me convert this to healthcare. So Horan's data warehouse has over 2 billion data points for our client base that are self-insured and are in our data warehouse. So how do we go about figuring out what are the right data points? So I wanted to break that down to make it a little bit more granular for you. So for every person that goes in and has an office visit, doesn't matter, specialty care, or they go to see their primary care, there's about 8 data points that come in through. And that could be demographics, that could be place of service, severity of claim. There's a lot of things that come in. Well, each member has about 4 office visits a year. So if you're an employer with 100 people, that's 3,200 data points just to consider on office visits alone. All right, this is one of those write those down slides. Put a big star by this. Your one piece of homework, everybody in the room. These are the data points that I want you to really focus on. These are the things that we really hope that you can rattle off the top of your head. So if you're president, if you're a superintendent, if your boss asks you, what's going on with our health plan? These are the points that you need to rattle off quickly. First is how you compare to others. This is just looking at the market. So on average in the market, an employer, the healthcare cost per employee per year is $11,600. How do you compare to that? How did you compare to last year? National trends are around 7.5%. We have 7.4% on the slide. So how did your healthcare cost increase compared to national numbers? How did if you're self-funded employer, how did your claim costs and administrative costs compare to expected? Were you at expected, over expected, under expected? And then we start to get into, if you're fully insured, what's your loss ratio? So you should be around an 80 to 85% loss ratio. That's kind of the expected number for a fully insured client. And then we start to get into the clinical side of things. How many of your folks had a compliant primary care visit? What are your top 3 conditions? What are your current high claimants and what does it look like they're going to happen in the future? And then what are the top prescriptions by cost and by volume? Those are really important. We're starting to see this shift in prescription. You'll hear a lot more from Michael here in a minute. We used to say prescription cost represented 20% of your spend. Now it's closer to 30% of your spend. It continues to go up year over year. So no matter what you're doing with March Madness in your business and healthcare, these are some themes that you want to try to remember. Always know what you're trying to achieve. State your goals very, very clearly. And what you really need to do with those goals is make sure you're simplifying them and you have clear metrics that are quantifiable. Write it down. It's very important as you go through. I always ask people, if you had to look at yourself and know that you had a good year, how would you know? And then outcomes that haven't occurred in the past doesn't mean they won't happen in the future. So don't dismiss things that have never happened before. Who knew we were going to have a pandemic? That hasn't happened in any of our lifetime. And that really screwed up a lot of things, from whether it was our business or staffing or work from home policies or some of the delays we had in claims for COVID. And then the last thing is process outweighs results every single time. So make sure when you set the other 3 metrics up that you're looking at creating a repeatable process and you continue to do it time in and time out. So when you walk away today and you think about data, I'm going to leave you with 3 different points over the next couple of slides. This is one of those write those down slides. I talked about primary care visit adherence. I'm going to pick on the Horan HR team that is sitting in the front row. We love this metric. They hate this metric because they are chasing down all of our employees currently to get them to make sure that they fill out their form and have seen their primary care. We do believe this is very, very important. And why is that? It's because members that see a primary care physician cost 11% less than employees that don't. Spouses are 21% less than spouses that don't see a primary care. This doesn't necessarily have to be for a physical. We looked at the data and we looked at it over those 2 billion data points. And we just wanted to look down the lens of who saw a primary care. Could be for a sick visit, could be for a primary care, for a preventive visit. But people that did that were by and large a lot cheaper over the course of the health plan. So make sure you have an incentive in place. Best in class incentive. This is one of those, put a star next to it. $600 incentive for your employee, another $600 for the spouse. We see that $600 incentive is what starts to move the needle and get people excited enough to go. Less than that, we see a dramatic drop off of people that will actually take it upon themselves and not have the Horan HR team track them down. But we see a much bigger incentive in people moving on their own. So let me give you a real life example. This is a study we did over 5 different employers. The average enrolled or the enrolled employee count was about 400 lives here. If you actually look back to 2016, this group of people put in, or this group of employers put in a preventive care, primary care incentive back in 2016. We also tracked how they were performing on a per employee per year basis prior to that in 2016 and then after. We used a really conservative trend line. Remember I said it was 7.5%. We actually used 6% for the purposes of this chart. Look at the difference on how they performed after that incentive going out to 2022. They're running at less than $11,000 per employee per year. It's a significant difference. The result was actually less than a 1% trend over that time frame. So they, in this particular group, their average incentive, it did vary by the employer that was in the group, but the average incentive was $1,200 per participant. And they got 93% average participation across the board. All right, so that's one. So remember primary care. Now we talked a little bit about medication. We know without a shadow of a doubt, when we look at the data, chronic conditions are prevalent in all of our populations when we look at things, and chronic conditions drive the bulk of our healthcare spend. When we look at that, that's going to be the top 3 that I would always say that we see in almost every population: diabetes, hypertension, cholesterol. So those 3 will always pop up in some way, shape, or form. We also know, so we looked at hypertension here. We also know that unmanaged hypertension costs 200% more than managed hypertension. Hypertension and high blood pressure is very easily managed using medications. High blood pressure medications are actually super cheap today too. So what would I want to do potentially to incentivize my employees to take these types of preventive medications is you can implement a preventive drug list. For self-insured employers, this is very, very easy to do. There are some alternative options to do on the fully insured side. We typically see, and the reason why that's important, we typically see about a 3 to 5% increase in your actual drug spend in year 1 by putting in that primary care list. But for every, well, I'll just show you. For every 10% increase in adherence, we see a 2% decrease in your medical cost. Remember, your medical cost is 70 to 75% of the total. So as you increase adherence, you have a significant reduction in your medical spend because people are managing those top 3 conditions. All right, so we got primary care, medication adherence, and then the last one. So we've seen a huge increase in specialty medications, and it's probably on everybody's plan. They've seen Humira. Michael's going to talk about it in a lot more detail than I am. He's going to bore you further than I am.
That's not true.
But medications on the market that are more than $1,000 have become rampant. Less than 2% of the population takes those medications, and they drive more than 50% of the total prescription spend on your plans. So what do I do about that? A lot of those are the injectable medications. On the self-insured side of things, there are some ways that you can very easily change your plan to maximize manufacturer assistance. Some of you are actually doing this in the room as I look around and I see some of the employers in the room. We've seen significant improvement in, one, the affordability for the member of those high-cost medications. The employer sees a dramatic reduction of up to 30 to 40% of their total drug spend because that risk is now removed from the plan. So it helps the individual and it helps the plan overall. On a fully insured side, you do have options on a fully insured side where carriers have implemented some programs behind the scenes that can get people into the right place and still have access to those medications. But this is an example of an employer that has 400 people. They put in a program like this focused on these specialty medications. And in the first year, they had a 28% reduction in their pharmacy spend, which generated about $100,000 return. We looked at one last week, current employer that was going through a renewal. The number was $1.2 million for 420 people. And that was just the mix that they were looking at on their particular plan. So the three things to focus on if you walked away, whether you have access to data or not, we can tell you, we know that these strategies work, that even if you're not looking at your own data, we know if you put in primary care incentive, if you get people to be adherent with their medications and you focus on your specialty medications, you will have the most likelihood to be able to control the costs in your plan on a long-term basis. All right, now my Debbie Downer slide, if that wasn't enough. So these are the things that keep me up a little bit. You're gonna hear a lot more on the gene therapy side of things from Michael when he gets up here. For those of you that have not experienced it, it's unlikely that you would, because it's a very, very low percentage of folks that would have taken one of these gene therapies. These are brand new into the marketplace. While they looked at as medications, they're administered on the medical side. They actually go in and alter your gene sequence. They alter your DNA to cure things like childhood blindness, hemophilia A, and these gene therapies have price tags of over $3 million. So Michael will go into that more. It's something that we're very, very in tune to. We continue to watch because we know this is something on the horizon that is a potential risk to the plans. The second thing is financial pressure on the hospital systems. I use Cleveland Clinic as an example here, but they actually posted a $200 million loss in 2022. Here locally, if you're on an Anthem plan, you probably know that Anthem and Christ Hospital are in the middle of a negotiation. Same things that we're going to start to see. Christ Hospital probably wants this and Anthem probably wants this, and they're trying to find somewhere in the middle. And we're going to all experience that over the course of the next really 3 years, as a lot of these systems are coming out of significant financial pressures, mostly related to staffing. And then the last is prevalence of high claims. This is nothing new. This has been on my list forever. But high claims continue to increase. And there was a 19% increase in high claims from 20 to 21. And we're continuing to see the high claims, both the frequency and severity, continue to go up as advancements in healthcare and technology continue to play in. So we'll be around after. You can always ask us more questions.
All right, thanks, Mike. Again, these are, we're in reality land. We weren't here to sell puppies and kittens, but no, your Horan team's here to help you as you devise solutions. I love that slide on primary care and health awareness, because it gives you that encouragement that those who really committed to it did see results. You're not going to see results in 6 months, but over time you are going to see those results, and they're real. And I have to remind Michelle and Jamie here, because again, they are chasing down primary care by the end of this month for Horan. So pharmacy. Okay, so now we're getting into area with staggering change. And you you think about, I was in my P&G days, my last stint was in the pharmaceutical division. And I used to think our $80 osteoporosis drug a month was a big deal. And that's just, we're so past that now. We're so past that. Here's the most amazing things. These drugs are actually targeting the biology of disease, which is life-changing. But someone has to pay for it. And that's the challenge you all have and we have as employers. And so as we think about this, there's a couple facts in pharmacy you should be aware of. Drugs have increased 17% in a compounded annual growth rate in cost from 2016 to 2019. That's again, this addition of the specialty. In 2018, drugs over $1,000 represented 44%. They now represent 60%. And then Mike was talking about his ability not to sleep when it keeps him up. 2 nights ago, I had insomnia, so I read the New York Times trying to make myself fall asleep again. And there was a study from Brigham and Women's Hospital in Boston. And this is a staggering it just kept me up. It didn't make me fall back asleep. The median price for a new drugs coming to the market is currently $180,000. Does anyone, not these people up here, want to guess what it was in 2008? It's $180,000 now for a new drug. What did a new drug, new technology cost in 2008 on average? Throw out a number.
10,000.
10,000. Anyone else want to throw out?
1,000.
80,000. $2,100. Carrie, you don't get to answer. $2,100. So this is where, but again, there are life-changing pieces to many these drugs and cures, but it's real and we're all facing it. So the good news at Horan, we have Michael Jeffries, who's a senior benefit consultant. Michael took on this pharmacy journey about 9-10 years ago and made it a priority for us at Horan. We have certified specialists, we have consultants, and we dive into every angle of pharmacy because it is going to be the topic we will be talking many more times in years to come. So Michael.
Maybe we are selling puppies and kittens. Who knows?
No
So-
puppies, no kids.
No puppies, no kittens. So pharmacy prepping, what Val was talking about is a staggering environment right now. Lots of changes going on. We want to talk about where we were, where things are going to be, into some concerns, some questions, and some conversations that you need to have. But to add to her statistics, I read this the other day. For all the ad revenue on television right now, 75% of it is for prescription drugs. Think about that. Every time you turn on the TV, it's always sponsored by Pfizer. That's how big of a market we're talking about. That's how they're making all of this money. And that's why we're seeing all these staggering costs. So where were we in the past? Historically, it was, we were in the dark. We had 3 big PBMs that controlled about 76% of all the claims volume. And those PBM, the pharmacy benefit managers, those are the big names that we know of. That's your Optums, that's your CVS Caremarks, that's your ESIs. And they had such a stranglehold on the market that there was not a lot of flexibility. There were not a lot of options. They basically controlled everything. And what that meant is there was a severe lack of transparency because the traditional contracts that we saw operated like this, is that they would price the risk based on your employer size alone. They would have you focus on trying to leverage your discounts, leverage your rebates, leverage your dispensing fees. But here's what they're not telling you is the discount that they're giving you is different than the discount that they're reimbursing the pharmacist. And guess what? They're taking the spread. Dispensing fees they're charging you is one. Dispensing fee they're charging them is another. They're taking the spread. How much do you think they're making on that spread? They're never going to tell you that. There's lack of transparency. So you don't know how much they're making to know if you got a good deal or not, unless they're just telling you that you got a good deal. That coupled with the barriers to carving out, because most people were carved in, meaning you keep the pharmacy with the medical carrier. So the barriers to carve out, whether they're real or perceived, kept people from thinking it was a real opportunity. First was carve out fees. When you try to leave your PBM and carve it out to somebody else, the medical carrier is going to charge you a carve out fee. Now that carve out fee varies in size per employee per month. They're going to tell you it's because they need that to maintain the integration of the medical and the pharmacy because you're tearing it apart and everything's going to fall apart. And it's going to be a big mess. That's their lost margin. They're just trying to get it back. And they're going to charge you that to eat into the proposed savings of the other opportunity that you're looking at. So it looks less attractive. So you don't want to do it. The other is the spear of disruption. That you think if you go from one PBM to another PBM, that all hell is going to break loose. All the drugs aren't going to be covered anymore. Things are going to move all over the place. So there's some apprehension. And then lastly, there's the dreaded 2 ID card problem. Everybody's used to having 1 ID card, and the thought of having people have 2 ID cards, everybody's like, well, that's enough. We're not going to do it. So that's where the market was. Everybody just kind of did what they did, hoped their contract was pretty strong. However, where we are today, things are evolving. More opportunity. There's a lot more flexibility. We're starting to see the rise of the boutique PBMs. These are the smaller PBMs that you may not have heard of that are really starting to gain traction. And they're doing it through increased transparency. So rather than having this this price differentials that we were talking about, the spread pricing. Now there's more transparency. They're just going to charge you a fee or charge you per prescription, and whatever they get the drug for, that's what they're going to invoice you for. So you can actually follow the money to figure out what they're making and what your deal looks like. But you're also seeing more options. Now we're starting to see group purchasing. Group purchasing is rather than your pricing being based on your employer by themselves, you're now becoming part of a bigger captive, a bigger consortium. So rather than get pricing on a 180 life group, you're now getting contract as part of a 10,000 life group. Discounts start getting better. Rebates start getting better. Dispensing fees start coming down. You start getting leverage. And just that alone will save you on average about 15 to 18% of your pharmacy spend. That wasn't always the option. And then if you step further down the progression, now we're seeing the rise of the alternative funding. That's the specialty drugs that Mike was just talking about. These concierge services that partner with these boutique firms offer increased transparency. Plus, they're now maximizing the alternative funding mechanism, which is primarily manufacturer assistance, where you get the drug for free. Doesn't cost you anything, doesn't cost the member anything. And they also look at international procurement. Those sort of solutions, we're seeing 30 to 40% off of your pharmacy savings. And guess what? The fear, the disruption, all those barriers, they're all starting to go away because these new options eat in and start to remove the apprehension. The carve-out fees, the savings are so large on these other opportunities that the carve-out fees, while they're annoying, don't make the alternatives less attractive because the savings is so large, it makes it, there's more of an incentive to do so. 2 ID cards, guess what? Nobody flipped out. Everybody's good with having 2 ID cards and 2 PBM carriers. Because why? Because the boutique PBMs and the concierge services are supporting with the communication campaign to let them know, here's how it works. You're going to get it in the mail. Here's how you process your claims. Very simple. So it's becoming a more transparent, more informed market for both the employer as well as the consumer, because the consumer is getting a lot wiser, not only about where they're getting the prescription, but the actual true cost is. But there's some variables that are coming into the new market. First one is the biosimilars. I'm sure everybody's probably heard about biosimilars, right? There's 33 of them in the market right now. The thing to understand about a biosimilar is highly similar. There's the common mistake that they think biosimilars are simply a generic alternative. They are not generics. They are not exact replicants of the brand name that they're competing with. They're highly similar, meaning that they're supposed to produce the same outcomes. Good thing is they're a lot less expensive than the brand names so far. Now, why I say so far? Because here's what's going to happen in the biosimilar market. The brands, they're going to react to this. Because why they may be less expensive from a growth standpoint, the brand manufacturers, they got a lot of money. So to stay competitive, what are they going to do? They're going to start throwing more rebates at the price of their brand name. It's going to start bringing the price down. They're going to start doing heavier marketing. So that 75% you just heard about, it's probably going to go to 80. You're going to see even more commercials at night. Very exciting for everyone. More running through the fields, bathtubs, that sort of thing, right? But you're also going to see more anti-biosimilar messaging. So they're going to start playing the fear card. You don't want to do what? You want to walk away from us. Why? Because it's similar. It's not the same, but it's highly similar. But their attack is going to get a counterpunch from the biosimilars. So if one's throwing more rebates, guess what the biosimilars are going to start doing? They're going to start offering rebates. Let's just race the price to the bottom. That's fine with me. That's going to benefit the employer. That's going to benefit the member. So let them just trade rebate punches all day long. I think they're probably going to get into financial assistance programs as well, because they want to be able to make theirs more attractive to combat against the price. And they're going to want to get preferred status on the formulary on your drug list. So a brand may be tier 3, they're going to want to get on a tier 2 or tier 1. The PBM, depending on what's going to happen, will determine what the tiering is going to look like. The one thing to understand with biosimilars is them hitting the market is not instantly going to bring everything down, and the adoption rate is not going to be immediate. If you recall, when generics first came out, it took 8 or 9 years before we got generic compliance levels to like 85, 90% now. The adoption rate is going to take time because of all these variables that are going on. Because if somebody's perfectly has their condition under control, why would they leave Humira? if it costs them the same amount, even though the cost is coming less, their copay may be a little bit different. And there's 7 of them coming out right now. And Humira's got a lot of money. Their global sales, $20 billion a year. The second in the market is like $9 billion. That's what a behemoth they are. That's how much resources they have that they're going to attack this. But be aware, I think they are going to have some impact. It's just, we have to be patient about the adoption rate to see how long it's going to take before it adopts. But I think it will bring some price relief. Which then takes us into the even bigger hitter that Mike was referring to. That's gene therapy. Gene therapy is a complete game changer. I hate using that phrase, but it is. There's 17 of them in the market right now. Average cost is $1.5 million. Now, they have potential for high health benefits. This could change somebody's life. Hell, this could save somebody's life. But you got to understand the variables. For the employer, there's a high upfront risk because this is not something that gets spread out over time. This is a hit. And it's a one time. And the other thing is the effectiveness of the gene therapy. Just because the FDA approved it, just because it's out there, doesn't guarantee the effectiveness of the solution. So it may work, it may not work, it may work a little. So what's the market going to do with the gene therapies? As an employer, what you need to be concerned about first is the stop loss concern. So if you're a self-funded medical plan, odds are that's going to be lasered out. Stop loss carrier is not going to want to take that on. They're going to say, oh, you can keep your stop loss protection for everything else, but that's $1.5 million on that one right over there because we know it's a one-time hit. But there are potential solutions that are being worked on. Some of them in their infancy stages, some a little bit further along the spectrum, but they're looking at things like performance-based contracts with the manufacturer. It says, okay, that's fine. We'll cover the drug, but it has to hit certain metrics over time. If we don't see the condition improving, you owe us money back. Similar with like a warranty. After 18 months, if we don't see the cost coming down for that condition for that individual, you pay us money back. They're also looking at captives, everybody coming together collectively, pooling money together. There's the Netflix approach, sure, subscription models. You pay a PEPM cost. Before the risk hits the plan, you pay it in the event of. Or, which is the one highlighted, you take the bold stance and you just exclude it altogether. Just don't cover them. That's a tough conversation. And that's why we're working right now to figure out what all the carriers, all the PBMs are doing, well, primarily the carriers because it runs through the medical side. What are they doing with gene therapies? Because the initial questions we're asking of all of them right now, you kind of get that's a really good question. We're going to work on that one. So with gene therapies, you basically have one of two options. You can either close your eyes, hope it doesn't happen, hope for the best, because you're talking about a lightning strike. You see the example in the upper right-hand corner, Roctavian, cures hemophilia. It impacts 0.1% of the US population. That's about 30,000 people. Impacts 1 of every 5,000 births. So the odds of you having somebody on your plan that has that or a dependent that has it is very, very small. But when it hits, it's a bomb. Which brings up the conversation because there's two sides of the coin. One is just rational risk management. You're like, oh, we can't afford that. That could bankrupt somebody, that could bankrupt a company. But at the same time, this is the opportunity that when you want to take care of your culture, this could save somebody's life. So you want to be prepared and understand the variables so you have the conversation up front before something happens, before it hits the plan. Now, when I say it's a lightning strike, not to say it doesn't happen, we have these in some of our clients in our book of business. So it does occur, but you need to have the conversation that cost versus culture, because there's a fine line between the two of them and understanding what these solutions are so that you can figure out how to cost contain moving forward. So more to come. They're really, really new. We'll keep an eye on it. We'll keep you updated as we learn more. Yes, sir.
I have 2 questions. The first one is, I'll combine it to one.
You can do 2, that's fine. No, I was running. This was the first one before you got to the second one.
So the first one is, have you heard of anything about diabetic drugs for weight loss?
Yes.
And so a lot of companies or providers aren't covering them because folks are not diabetic. Thoughts on that?
So the question is, you hear about the diabetic drugs that help promote weight loss. And what's my stance on that? Yes, I have heard about them. So this is an opportunity where these drugs that have brand name drugs, that they want to keep the patent as long as they can. And how they keep the patent as long as they can is they keep coming up with other iterations. It also treats this, it also treats this, it also treats this. This is a new ripple into that equation right now. So some of these name brand diabetic drugs do have the opportunity to do it. Now, as far as them being covered, that's going to go through formulary protocol with the PBM. So they're going to figure out what's the actual efficacy of it. What are there any sort of side effects? And if they were, what tiering is it going to happen? Is it going to occur? And does it really impact the weight loss and bring medical claims down? I think it's still too early to speak on it, but I do think you're probably going to see an entrance of those, not necessarily an entrance approval, probably within the next 18, 24 months on that.
The second question is, Mark Cuban came out with some pharmacy.
He's going to save the world.
Correct.
Yep.
What are your thoughts on that?
Great question. Question was on Mark Cuban's solution. So Mark Cuban's solution right now is primarily generics, which are great. So pennies on the dollar, which makes up not a large portion of your cost, but makes up a big part of your volume. So the fact that they're able to offer that even a lower cost to help drive adherence, I think is fantastic because that prevents complications so it doesn't compound into another situation. If he can figure out how to get into the brand game, which he's thinking about right now, actually building his own facility, I welcome it. I think it's a great idea. I think big pharma is going to, like anything else, they're territorial. They're going to start to react to that, and something is going to happen to combat the way he's going to do it, be able to do it less expensive, much like the biosimilars. He'll be able to say, yeah, I can do that brand name, and I can do it cheaper. They'll just start throwing rebates at it, or they'll start selling against it. But I think overall, it's going to bring the right market pressure and bring more transparency and help drive the cost down. But I think it's going to be a battle.
That's something Haran's helping with, or can any person just go and
Any person can do it.
cost?
It sits outside of your plan right now.
Correct.
It does. Now he's working to be able to integrate that into the plan as he expands. He's still working out the kinks from a brand name standpoint, because right now he has no incentive to integrate with the plan right now. He just wants to just turn that on, just like GoodRx or any of those other options where people just go online and do their own shopping on it. But I think like anything else he approaches, I think it's got some real legs to it. It's a great question. So strategies. Well, from a PBM standpoint, if you're self-funded, consider a market bid. There are savings on the table. Even if you go out on your own, just on your own, you're probably looking at 5 to 7% savings. But look at that leverage purchasing. Look at the alternative funding to really see what options are out there. Take care of get your savings, but also benefit the member as well as the employer. Look at pass-through pricing. If you have a spread pricing program right now, see what the other options are. Get more transparency so you can follow the money, understand what they're making and what you're getting. If you're fully insured, just be aware of the market dynamics, everything that we're talking about today, because it does have impact on your renewal. What's it going to do to your rates if biosimilars start coming through, if a gene therapy comes through? But also consider a retro analysis. If you've always been fully insured and you're thinking, well, maybe it could be self-funded, we can help you do a retro analysis to answer that question of what if. Over the last 3 years, what if we would have been self-funded? What would it have looked like? Because at the end of the day, all I want you to do is just make an informed decision. Just because your size don't think that you can't be self-funded, at least look at it as an option to see the viability. Biosimilars versus brands, just understand how it works underneath your pharmacy benefit. Understand what impact it's going to have to specialties. Is it going to shove specialty over? Is specialty going to have more parameters? Is it going to get more attractive? And look at the cost containment options. Same thing for gene therapy, same exact approach. Understand how it's being covered underneath your medical plan. What happens to your renewal if it hits? What's the stop loss impact? What's the carve out? What's the turnover going to be? And then lastly, again, what those cost containment options look like. Just be aware, because it's an exciting time. Because pharmacy used to always be the last 15 minutes of the conversation. It's now the beginning of the conversation when we're looking at utilization. So lastly, considerations as you prep. Keep in mind, it's an evolving PBM market. There's savings on the table. Please take advantage of it. Bio versus brand. I'll just sit back and watch. It's going to be a brawl. So excited for it. I think at the end of the day, it's going to have market pressure. It's going to bring the cost down. But just keep in mind the adoption rate. I do think it's going to take a while before it gets to a higher level. And then gene therapy, Again, just a different beast. Understand the exposure, have that conversation, cost versus culture, have an understanding of what stance you want to take before it hits, even if it does hit, just so again, all leadership can make an informed decision. Right? All right. Thank you.
Thanks, Michael. Okay. That's all right. That's mine. So we are into our last chapter. And again, all of this is a lot and we recognize that. And so what we want to do is get to an end that's a little bit more of an uplift. So first off, you should know that there is a coffee bar set up outside for when you leave to have a pick-me-up. So you get to look forward for that. But as we think about our total rewards, we like to think of the benefits ecosystem in just really simple terms. You have your core benefits, which is your base. You have what we call like your cost containment or your outcome improvement, which is in that middle. And then you have what we would call the total rewards or perks. And that's where some of them may be actual benefits, some of them may be programs, but they really enhance your package. So why are employers even looking at this? Well, the concept is trying to connect your business strategies or your organizational strategies to different program that ultimately helps you recruit and retain. As we look at this, all of you are uniquely facing a challenge around talent. The statistic that has come out is that there are 11 million job openings with 6 million available people. And that is based on the declining workforce, people retiring, and we're not having an increase in population in ways that will sustain that. So this will continue as you look for talent. And so some other things that employers are facing is how do you take all the things that matter to you in your business goals and start applying them in unique ways into benefits? Your workforce is changing. Some statistics that came through this are things like student loans. They're real, right? They may be real for different parts of your population than others. Statistics say that women carry 2/3 of the debt and minority women carry the highest balances. Well, you need to know that as you look at your population and your workforce on what you're going to do. And as you think about your audience, the LGBTQ environment is real for all of you. 8 million are in our population identifying that way. 38% are parents, which affects a lot of your policies and things and the different perks you think. And this is not any political representation. This is you guys facing the changing workforce, what's in it, and how you're going to address your recruitment and retainment. As you think about all of these pieces, this is the uplifting part. We have Cheryl Muller, who is our president and managing principal for Dayton and Columbus. And what's so special about Cheryl that you get is she truly is a pioneer. And when you think about this area, you've got to have that pioneer mindset. So there's no one better than Cheryl to bring that.
Thank you. Okay, we're in the home stretch. We got less than 20 minutes and we are going to wrap things up. I may go a little quick. So this does work? Okay. So I just want to, if you guys need to take a break, I had to get up and stretch, but feel free. But I want to start by asking, with all of the headaches associated with offering benefits, I sat through this seminar yesterday and today, and we have it again tomorrow. And this is heavy stuff. This is a lot of problems that you all are trying to solve. So with all the headaches associated with offering benefits in the first place, I like to just rewind and level set and remind ourselves why we do this. So there's no wrong answer. There's one right answer, but there's no wrong answer. And anybody, why do we offer benefits to our employees? What's that? Competitive advantage. Anybody else?
Show them we care.
Show them we care.
Take talent.
Retain talent. Those are all right. They're all accurate. I like to use this slide. If there's one thing that you take away, remember this, because the reason that we offer benefits. So why would I even care about health insurance? Why don't I just give you money? Like if you're my employee, I'll just pay you to come and work for me. Why benefits? So I like this slide because it just reinforces the labor force was tight and the demand for goods was high during World War II. Supply of workers was low. So there was a talent war. Sound familiar? We're kind of facing that today. Fringe benefits. So the law went in place that prohibited wage increases to attract employees. So when you couldn't give people more money to come and work for you, how were you going to recruit and retain employees? So fringe benefits were not considered wages according to a federal ruling. And there was created enormous tax advantage for employer-sponsored health benefits. And so by the mid-1960s, employer-sponsored health benefits were almost universal. So now the world looks at employee benefits almost as an entitlement, but just remember that they were used as a recruiting tool. So as long as you have the opportunity to offer benefits in lieu of cash, everybody wins. They're not taxed and you are not taxed as an organization to do so. So I always like to start with that slide. That said, the demand for talent is real. So there's a war talent out there. So 4.1 million workers left their jobs in December. We meet with hundreds of employers on a regular basis. People are ghosting their interviews. It's hard to get people to stay and it's hard to get good people. So ultimately, the purpose of employee benefits is to recruit, retain, protect, and sustain your workforce. And so if you just always remember that that's what we're doing this for, I think that just helps keep things in mind. So with that, I also like to add that what you guys are doing on a regular basis, I like to stop and pause and thank Michael and Shelly and Mike Lakin and all the people and all of you that do what you do, because you're doing the hard work. And sometimes I think our employees forget how hard you're working to bring them these benefits, and benefits are a gift. If you think about this, for reference, the average benefits load in the United States, according to the Bureau of Labor and Statistics, is 31.7. So in addition to the compensation that an employer is giving to their employees, there's also this hidden paycheck. And people take that for granted a lot. So I mentioned it's almost like an entitlement. Benefits these days are like a defensive move. You have to have them in order to recruit in the first place. But a lot of times people are not delighted by them. They're not calling their friends and being like, hey, let me tell you about this cool medical plan I got. So you have to have them. So we've done some research, and I would like to think the value of employee benefits and perks. I want to pause and say, what's the difference between an employee benefit and an employee perk? And this is not formal training. This is just me talking, but benefits are what employees need. Employees need benefits. They need medical coverage. They need dental, vision, life insurance, disability coverages, things that would be considered risk mitigation and sleep at night protection. As an employer, that's something that you can offer to your employees, and you can feel good that they feel good and everybody's protected. But the perks are things that delight them. Perks are things that you might tell your friend about. I use the example that I was at the gym the other day, and I overheard this woman telling somebody that her company gave her $25 to go to the gym. Well, you know how much we spend on medical plans? And she's telling her buddy about the $25 she just got. So it's the things that we're trying to do to delight your employees, to think about how you increase employee engagement, attract, engage, and retain. So just keep those things in mind, the delighting of your employees. And so there's so many ways that you can do it. There's lots and lots and lots of options, and we're going to talk a little bit about that. So if I were to ask the audience, what kind of perks and extras benefits are you offering to your employee base that delights them? I know what we do here at Horan, and it's a lot of really cool stuff. And I know that it's a lot of work for our team. So I imagine that it's a lot of work for you guys as well. So how do you know what's good and what's not? I'll use this slide just real quickly one more time. The fundamentals of your package are things that you already know about: fair pay, safe place to work. You've got a thriving culture. You want to have some community involvement. And then you have your essentials, which is your defensive move, which we just talked about: medical, dental, vision, disability coverages. A lot of times that's accident, critical illness, hospital indemnity coverages. And then the perks. It's all these extras that are available in the market. And so as the market is changing, we start thinking about future prepping for your plan. Start thinking about the different things that it would take to entice or recruit or retain your employee. So I use this slide because years ago, I'm older now and it might be harder to recruit me away from Horan, but back in the day when my kids were little and if someone said, Cheryl, we will pay you the same amount of money. So if money is equal, if compensation is equal, but we're going to help you with some other things. I remember thinking, oh, good God, could you watch my kids, do my laundry, make my dinner, clean my house, run a few errands, get the groceries, watch the dog pick me up for work? If there was something that an employer could do to make my life easier and it wasn't related to compensation, so these might be the perks, employers are doing these things now. So if if you haven't been paying attention to this stuff, start thinking of the ways that maybe you could make their life better. So I was talking to one of the hospitals in Dayton, and they have a hard time with transportation and getting their employees to work. They have an Uber program or transportation programs where they're helping people get back and forth to work. You know what people love? Food. They love food. If you have anything that is dinner, I mean, Haran has a program that in the evenings during fourth quarter, because we're all slammed, we're working a lot, and Haran gets us food, dinner that we can take home to our family. It's great. And I just like to add that over the years, what was important to me and what's important to your employees is going to change. So keep in mind about some of the flexibility and the different options that people want. And so we did a survey and we asked, what's the perkiest perk? So when I did this presentation, I did it in October, and it was called the perkiest perks, total reward strategy, totally. And so what we're looking for is what's the most important perk that you can find, and what would your employees hate to see end? I want to show you, these are a few of the employer groups that we interviewed. So we went and interviewed them. And I wanted to know, what are you doing that's above and beyond the traditional scope of benefits and the packages that you're offering today? So we got a lot of answers. I'm going to start by telling you, I did not find the organization that measured the value of the perks that they're giving. So we do a lot of cool happy hours in the afternoons, and we do a lot to delight our employees. Is it working? Do we know if it's working? Do you guys know if it's working? There was a lot of cool things that employers are doing. So one of my favorites was Victoria's Secret. They offer so many cool things to their employees. They couldn't even name them all. I almost got lost in how many extras they offered. But so for example, some of the things that we hear about: Medicare, Social Security support in your time of need. Employees find that to be a very valuable service that's offered to them. Paid time off for volunteering, all expenses paid vacation. Hey, a few of the things that were delighting them were theme boxes. So when there's a pregnancy, it's a bump box, or a, hey, it's fall y'all box, and a welcome aboard box. So there's lots of really cool extras that employers are facing. Victoria's Secret did win. Their global benefits director, I finally said, like, is there anything else? Is there anything that you thought delighted your employees more than others? And she said, oh yeah, there's one thing. We brought in the Botox bus. And so I learned in that moment that one, know your audience, and two, find ways to delight them that's above and beyond. And I thought that was kind of neat. The conclusion that I found when we did all of these interviews, it was all across the board. I mean, free coffee, free food, free anything is delighting your employees. But I was looking for a theme, and I was looking for data points that I could support the fact that, yeah, perks and benefits are moving the needle, and they are really well received, and it is a gift, and it does move the needle. I could not find data that I felt strongly about that could support what the message was. But I came to a conclusion that when I think, what's the perkiest perk? It came down to flexibility, and flexibility not in your working hours. So I'm not talking about if you work from home or you work from work. I'm talking about the gift of flexibility in valuing what's important to you. So when we think about future prepping your benefits, I'm hoping you guys will spend some time thinking about the digital transformation that's coming related to how benefits are offered to your employees. Think about all the ways that you can buy things on Amazon, just at the click of a button, and it's easy and you understand it. Start thinking about your benefits in that way. So I have a slide up here that talks about let them decide. Flexibility is a really great option. If you haven't done any research on the lifestyle benefits, do a little research on that. And when you walk out of here, I like to say, like, if you get one nugget, write this down. Look up a product called level.com, level.com. And what it does is it allows employers to put funding into a bucket, and your employees can spend it however they see fit. So it can be in different categories. So there's a few examples that I like to use. Sometimes when we want to give a bonus of some sort, we're going to give a $25 Starbucks gift card. I don't like Starbucks. I want Dunkin' Donuts. And if you're in HR, you know exactly what I'm talking about. You do, because somebody always complains that you cannot make everybody happy. I spent a lot of years researching gym memberships so that people had access to gyms because employers are really excited about making sure that you're healthy. So that we're going to give you free access to a gym. My yoga studio is not part of that network. And you're going to hear about it and it's annoying. And you're trying to do a really good thing and you're trying to gift these benefits and they're not well received. And the intent is that they are well received. It's the gift of your benefit package. So I really love this type of product because through the digital transformation, instead of saying here's $25 to Starbucks, you can say, here's $25 to your well-being fund. And now, well, I don't like coffee. Awesome. You don't have to have coffee. You can have something else. So there's different categories that employers can place and put money into that are delighting their employees all the time. So if we go back to the basics, why are we doing this? Because we want to recruit, we want to retain, we want to delight, we want to improve the morale. And so all of those things combined give us the opportunity that we could be just, now we're back to the taxes. Some of these things are not tax-free. These are taxable. So if they're taxed, why don't we just give them money? Like I'll just give you more money in your paycheck. Why don't I just do that? Well, if you want credit, every time your employee opens that app and says, I want my education refunded, open the app and pay for it out of the funding that you as the employer are putting into that account. It's a way that they can access that and then thank you every single time they go in it. So I like to imagine this app as put a bow on it. You just put a bow on your benefits package and people can go in and select what's important to them. Like the old days of the cafeteria plans. If you guys remember the cafeteria plans, in theory, I love a good old fashioned cafeteria plan, but I never saw it executed well. The technology is coming that will allow employees to make these selections in a way that I think is really powerful. So if you get a minute, I think it's worth looking at. I like level.com because it's completely agnostic. It goes down to 2 employees. It's a technology platform. It'll talk to your payroll. It'll talk to your HRIS systems. So there's a lot that are out there, but just to get the gist, that would be a good one to look at. So there are some tax advantages, some non-tax, some taxable payouts that are all in there, but if you do get a minute, just take a look. So we'll speed things up. At the end of the day, use data to make decisions. You might be offering benefits or perks that nobody really cares about or values. And because it's so much work and there's so much compliance, you want data to support that it's really working. So let your employees decide. I think that's a great benefit in and of itself. And then how you market your benefits matters. Put a bow on it, make it pretty, make it attractive, and make it so that when the receiver of your benefit package opens it, it's a gift and they think, wow, thank you, employer. This was really great. So with that, we're going to wrap up. Sped through that. It's 1:24. Out of here with 6 minutes left. So any questions on any of these topics? I think there is
Sorry, Cheryl.
here we go.
So the perks piece with your section, I think too often, speaking on behalf of all of HR, you get somebody who says, hey, I read this article or I saw this story or, blah, 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 and this is the greatest thing. When you think about those companies that seem to have a good handle on it, how did they approach finding out what their employees wanted? How were they surveying them at a certain frequency? How are they connecting to figure out, not just giving them to decide, but what do they actually care about?
Yeah, there are a lot of surveys. My original deck had a lot of the surveys listed on it, like how are employees or how are employers getting access to that information? So if you guys didn't hear his question in the back, it's one thing to let them decide, but how do we let them decide what choices there even are in the first place? And there is a lot of survey data, but then it's also when you're dealing with agnostic, you can just build categories. So if you as an employer believe wellness is important, you have a wellness category. If you believe that family planning, which is different than some of the other things in the healthcare space, family planning is something that came up all the time. Family planning is its own category. So the benefits that fall within that is just money to be spent as you see fit. So there are surveys and there are surveys based on industry and employer size that you can use as comparisons.
Cheryl, just want to add to that as we think about the perks piece also, there's ways to look into your own data to understand what your population really made of. One of the facts we brought forward to a client who was looking at expanding their total rewards was an understanding in their manufacturing world that something like 56% of their population had families of 4 or more making 55,000. So what you offer them as an audience is going to look different than maybe what you offer different members. So it's part of that strategy you have to put in place of knowing your different stats in a different way to target, because you're not, and then it's the strategy of this is a group that we want this program. No program is going to fit anyone but your health insurance and your dental insurance. These are perks based on your strategy. So hopefully that gives you some perspective there.
Any other questions? You guys will receive a survey that goes out that's going to ask just a few questions. If there's anything that, any questions you want, you can put them on there. And if there's anything that we could do better, we'd love to hear about that. So with that, I think we're done. And your CE credits are available outside as well. So thank you all for coming, and coffee, don't forget.
July.
I hear that this.
I'm in HR too.